Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 359 of our pharmacotherapy series, which majors in asthma. The next case reads, TKW, a 33-year-old woman, presents to the clinic with a history of severe coughing and chest tightness after exercise. She recently joined an exercise club to lose weight, but is unable to keep up with others of her own age and relative condition when jogging outside. She recalls having mild respiratory problems as a young child, but has never taken any asthma medications. She has a positive treadmill test for exercise-induced asthma, abbreviated as EIA. So my question to you is, how should TKW be treated? During sustained exercise, at least 90% of patients with asthma experience an initial improvement in pulmonary functions quickly followed by a significant decline. This phenomenon may be the only symptom of subclinical asthma. Patients can be diagnosed by measuring the forced expiratory volume in 1 second or peak expiratory flow before and after exercise, 6 to 8 minute treadmill or bicycle exercise test. A reduction of forced expiratory volume in 1 second by more than 15% of the baseline value is a positive test. Hyperventilation of cold, dry air increases the sensitivity to exercise-induced asthma and induces bronchospasm. The main stimulus for exercise-induced asthma is respiratory heat loss, water loss, or both. While breathing heated, humidified air completely blocks exercise-induced asthma in many patients. Masks are indicated for patients with exercise-induced asthma in the wintertime, and patients with severe asthma accompanied by exercise-induced asthma also should be encouraged to swim or engage in other indoor exercise that does not promote exercise-induced asthma. A warm-up period before strenuous exercise is helpful in some patients. With appropriate pre-medication, most exercise-induced asthma can be prevented, so virtually all patients with stable asthma should be encouraged to exercise. The mechanism of bronchoconstriction after airway heat and water loss is still incompletely understood. Although several drugs inhibit exercise-induced asthma, short-acting inhaled beta-2 agonists are generally the agents of choice for prophylaxis. For typical periods of exercise, e.g., less than 3 hours, pre-treatment with agents such as albuterol 5 to 15 minutes before exercise usually provides excellent protection from exercise-induced asthma. For prolonged periods of exercise, long-acting inhaled beta-2 agonists, like formoterol or salmeterol, provide several hours of protection. Two differences in formoterol and salmeterol include the delivery systems for inhalation and the onset of action. If either of these agents is to be used to prevent exercise-induced asthma, it is important for the patient to inhale the medication at the proper time before exercise. Formoterol should be inhaled at least 15 minutes before exercise, and salmeterol administration should occur at least 30 minutes before vigorous activity. Patients who are receiving therapy every 12 hours with either drug concomitantly with inhaled corticosteroid for long-term control of asthma should already be protected and therefore only use albuterol if symptoms occur after exercise. With maintenance therapy, as opposed to single doses before exercise, bronchoprotection from exercise may be reduced to 5 hours with long-acting inhaled beta-2 agonists. Leukotriene receptor antagonists, e.g., montelukast once-daily chronic therapy, have also been demonstrated to prevent exercise-induced asthma. Finally, it is important to point out that in persistent asthma, long-term anti-inflammatory therapy is helpful in reducing the response to most asthma triggers, including exercise. For most patients who have exercise-induced asthma only, use of a short-acting inhaled beta-2 agonist 15 minutes before exercise is the only therapy needed. Because of the hyperventilation of relatively cool, dry air, jogging is a potent stimulus for exercise-induced asthma. A number of possible therapeutic interventions exist for TKW. She could be encouraged to swim because the inhalation of humidified warm air is less likely to produce exercise-induced asthma. However, if she wishes to continue jogging, 2 inhalations of a short-acting inhaled beta-2 agonist, e.g., albuterol, from a metered dose aerosol 15 minutes before exercise should provide adequate protection for 2 to 3 hours. If outdoor temperatures are quite cool or cold, TKW should jog indoors. TKW also should be counseled to take 2 additional inhalations if she breaks through the initial protection and experiences tightness. The next case reads, WSL, a 17-year-old boy, presents to the clinic with a complaint of dyspnea and coughing that has limited his ability to keep up with his basketball teammates. He states that it is worse when playing outdoors unless the gym is cold and that it seems to be worse, occurring sooner during exercise, than a month ago. WSL experienced several bouts of bronchitis as a young child, but has not had any problems for the past 6 years. His symptoms are consistent with exercise-induced asthma. So my question to you reads, how should his exercise-induced asthma be treated? WSL presents a special problem in that he is a teenager. Both for adolescents and children, peer pressure usually is extremely significant. Optimal prophylaxis is important to allow WSL to compete at his best level. Embarrassment about not keeping up with teammates can be very hurtful now, and it has implications for setting habits of exercise into adulthood. Many adults with asthma do not exercise because they think they cannot do so based on childhood experiences. Lack of exercise can have a negative impact on physiologic and psychologic well-being. WSL should receive preventive treatment with an inhaled beta-2 agonist. The question is whether he should receive a short-acting or a long-acting agent. The clinician should probe as to the duration of exercise. If WSL exercises for longer than 3 hours, formoterol or salmeterol administered 15 to 30 minutes before exercise would be a logical choice. Finally, the clinician should verify that exercise is the only factor that precipitates asthma symptoms. It could be that further questioning of WSL will reveal persistent asthma or mild intermittent asthma beyond exercise-induced asthma only. If that is the case, long-term inhaled corticosteroid or montelukast therapy should be started to reduce overall airway hyperresponsiveness. The next case reads, ABC, a 26-year-old woman, calls her clinician and states that she has run out of her albuterol metered dose inhaler. She has a prescription for a budesonide dry powder inhaler, but admits that she does not use this medication, because it doesn't seem to work as well as her albuterol metered dose inhaler. ABC has had asthma all of her life. She complains of symptoms most days but has not required visits to the accident and emergency department or hospitalizations. The provider determines that ABC is bothered most about daily shortness of breath and worries that her condition may get worse. So my question to you is, what should the provider do in this situation? If optimal long-term drug therapy of asthma is prescribed, treatment may still fail or be suboptimal if the patient does not receive adequate education. Patients with asthma require special educational efforts because of the use of inhalation devices and peak flow meters. In addition, it often is a major challenge to have patients and parents understand the critical importance of long-term daily controller therapy and environmental control. Of course, an important first step in educating asthma patients is to be caring and a good listener. Rather than sharing your knowledge initially, it is important to help establish partnership with the patient by first asking the following question: what is bothering you the most about your asthma? Really listening to the patient and then addressing patient concerns is extremely important to successful education and long-term management. Clinicians can be of invaluable assistance to the patient by repeatedly reinforcing education on the necessity of using anti-inflammatory and combined inhaled corticosteroid long-acting inhaled beta-2 agonist therapies on a regular schedule. Many patients underuse long-term preventive therapy because no health professional took the time to adequately instruct them that most asthma symptoms are preventable. Although underusing the most important medicines for long-term control, many patients overuse quick relievers, i.e., short-acting inhaled beta-2 agonists. Healthcare providers must be able to detect these problems and intervene to enhance patient care. Because a large percentage of patients have difficulty using metered dose inhalers, teaching patients the correct use of metered dose inhalers, alone or in combination with spacers, and dry powder inhalers is absolutely essential. In one study, 89% of patients could not perform all of the steps for metered dose inhaler use correctly. Competent teaching requires observation of the patient using the devices initially and again on repeat visits to the clinic, hospital, or community pharmacy. Telling the patient about correct use is inadequate. Health professionals must demonstrate use of the devices, live or with videotapes, for patients who cannot use the devices correctly. For videos that show proper use of many types of asthma inhalers, go to http://www.nationaljewish.org/healthinfo/multimedia/asthma-inhalers.aspx for a video of how to use a nebulizer. Go to http://www.nationaljewish.org/healthinfo/medications/lung-diseases/devices/instructions.aspx. Although there is more than one correct way to use a metered dose inhaler, many asthma experts prefer to use spacers to help ensure optimal efficacy. Spacers should be used in virtually all patients receiving inhaled corticosteroid via a metered dose inhaler, even those with perfect metered dose inhaler technique, because spacers enhance efficacy and reduce the risk of oropharyngeal candidiasis. On the other hand, spacers do not add efficacy to correct use of a beta-2 agonist metered dose inhaler. Although any spacer can be helpful, Marketed devices that are valved holding chambers and have a flow indicator whistle when inhalation is fast are preferred, e.g., aerochamber. Studies have shown that health professionals, like some patients, generally are not competent in using metered dose inhalers. Obviously, the clinician should practice with a placebo inhaler and gain competence before teaching a patient. Among clinicians who educate patients, pharmacists can be helpful in teaching correct use of metered dose inhalers. Unfortunately, one study showed that community pharmacists commonly are not providing such teaching. In addition to teaching the correct use of metered dose inhalers and spacers, clinicians should help patients via education regarding the correct use of breath-activated dry powder inhalers, e.g., twist haler, discus, aerolyzer, handy haler, and flex haler, and nebulizing machines. When using the flexhaler, for example, patients must clearly understand the need for a rapid, preferably 60 liters per minute, deep inhalation, not slow as with an metered dose inhaler. Such rapid peak inspiratory flow is achievable by some young children, but many children younger than 8 years of age have difficulty reaching peak inspiratory flow greater than 60 liters per minute. With the discus, peak inspiratory flow does not have to be as rapid as with flex haler, but it should be greater than 30 liters per minute. In addition, patients need to breath hold 10 seconds if possible, as with a metered dose inhaler. We will now briefly look at asthma self-management plans. Objective monitoring of lung function at home with the use of peak flow meters can be very helpful to patients and healthcare professionals. EPR3 discusses the debates about peak expiratory flow versus symptom-based action plans. Use of peak flow meters may be valuable in patients who have had severe exacerbations and those who are poor perceivers of deteriorating asthma control. Instructing patients on the correct use of the devices, including use of the green, yellow, and red zones, is essential. After establishing that optimal therapy has maintained the peak expiratory flow in the green zone in the early morning, most patients can simply verify their values once daily in the early morning. Analogous to a traffic light, green, yellow, and red zones have been established to guide the patient and clinician. The green zone refers to a peak expiratory flow that is 80% to 100% of personal best, and generally indicates that therapy is providing good control. Before a course of optimal therapy to attain a personal best, the zones are set based on predicted values found in each peak flow meter package insert. The yellow zone indicates a peak expiratory flow that is 50% to 79% of personal best. Patients should be instructed to call their physician or other healthcare provider for adjustment in preventive medication if the peak expiratory flow stays in the yellow zone after using 2 puffs of a beta-2 agonist. The red zone indicates a peak expiratory flow that is less than 50% of personal best. The patient should know to call his or her healthcare provider immediately if the use of an inhaled beta-2 agonist does not bring the peak expiratory flow to the yellow or green zone. Correct use of the peak flow meter includes standing, inhaling completely, forming a tight seal with the lips around the mouthpiece, exhaling as hard and fast as possible, also called a blast, and repeating this maneuver twice. The best of 3 attempts should be recorded. Beyond giving maximal effort when using peak flow meters, patients should be instructed to place the instrument well into the mouth on top of the tongue to avoid acceleration of air in the mouth with the tongue and buccal musculature. In essence, spitting into the peak flow meter causes a dramatic false elevation in peak expiratory flow. Some data suggest that women need more initial coaching than men in giving maximal effort when using peak flow meters to ensure accurate assessments of peak expiratory flow. ABC needs education regarding the benefits of long-term inhaled anti-inflammatory therapy. The clinician should explain with enthusiasm that ABC's budesonide is an extremely effective medicine and that it is the cornerstone of her asthma management. The delayed onset and safety of inhaled corticosteroid must be stressed, as well as the requirement of regular use every day. Teaching ABC the differences between preventers and quick relievers is essential. Showing her colored pictures, models, or a video of inflamed airways can be very helpful. These teaching aids are available from several pharmaceutical manufacturers. Likewise, a peak flow meter should be given to ABC, and correct use ensured by observing her use of it along with establishment of green, yellow, and red zones, coupled with a written action plan developed by her asthma care provider. ABC needs to hear from the clinicians treating her that asthma is preventable, and in the words of a title to an NIH booklet for patients, "Your asthma can be controlled. Expect nothing less." As part of comprehensive education, such a positive message from all of her caregivers, as well as carefully listening to ABC's concerns, can have a major impact on ABC, who has not been managing her asthma optimally. ABC tells the provider that she was previously instructed to place the albuterol metered dose inhaler in front of her open mouth, and spray rather than put the metered dose inhaler in her mouth. She says she is confused because the package insert shows placement of the inhaler in the mouth. So my question to you reads, what should the clinician tell ABC? ABC is correct that this is a confusing issue to many patients and health professionals. A small number of studies show that the open mouth technique is better, but several other studies with short-acting inhaled beta-2 agonists show that the closed mouth technique is as good as or better than putting the metered dose inhaler in front of the open mouth. In addition, the correctly performed closed-mouth technique is as efficacious with a beta-2 agonist as with a spacer or nebulizer. One caution with the open-mouth technique is that incorrect aiming of the metered dose inhaler may result in the aerosol being sprayed onto the face or into the eyes. Because the open-mouth technique has not been studied with the currently available metered dose inhalers, it is recommended that the closed-mouth technique be used because the non-chlorofluorocarbon metered dose inhalers were FDA approved using this method. Finally, regarding the hydrofluoroalkane metered dose inhalers, special care should be followed in cleaning the actuators. Healthcare professionals should stress the importance of regular metered dose inhaler actuator cleaning with their patients. My next question to you reads, for patients who are using both a bronchodilator and an anti-inflammatory inhaler, is there a preferred sequencing of the inhalers? For patients who have several inhalers, questions regarding sequencing of the inhalers are frequently asked. First, there is no well-documented evidence that outcomes are better using, for instance, a short-acting inhaled beta-2 agonist or an anti-inflammatory agent first. A common-sense approach is that using a short-acting inhaled beta-2 agonist first and then an anti-inflammatory second has some appeal, i.e., quick relief and theoretically enhanced penetration of the anti-inflammatory. However, as discussed previously, short-acting inhaled beta-2 agonists are preferred for as-needed use, and before exercise, and should not be used on a long-term scheduled basis. Thus, if a patient is not symptomatic at the time the anti-inflammatory is scheduled, current literature suggests that the patient inhales only the anti-inflammatory agent. Because time is limited in counseling patients and teaching them correct inhalation technique, the purpose of each medication, controllers versus quick relievers, and the need for strict adherence to controller therapies are far more important than spending precious time on the sequencing of inhalers. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 360.